Thursday, August 22nd. I'm Adam Walsh, and this is The Signal. Today's show topic, mental health care. We will talk about the roles of mental health professionals and the system they work in. We'll ask and answer, what are the gaps? What are the barriers? And what are the fixes? So there are issues and challenges facing the mental health care system, right? We're going to go over some of those today. Thinking off the top of my head, staffing, barriers to care, the toll it takes on our health professionals. We will talk about our collective understanding and our perhaps misunderstanding of the system. And we'll hear about ideas and solutions to the challenges of today, right? What fixes could mean for the system for like tomorrow and beyond. All of this, as we've talked a lot over the last couple of years about the health accord, we've talked a lot about social determinants of health, and as this system is being revamped, recharged, retooled, whatever you want to call it, the questions I have, it's, well, what do the boots on the ground have to say? My guests today, so two of my guests are part of the Association of Allied Health Professionals, and the others with the Canadian Mental Health Association of Newfoundland and Labrador. So Sean Kennedy chaired the board with the CMA and CMHA and NL. I'll get the letters out eventually. How you doing?
Yeah, we'll get the letters straight for sure. I'm great. Thanks so much for having me.
Thanks for coming in. Danielle Hogan, a licensed registered occupational therapist. How are you doing?
I'm doing good.
And Dr. Jody Spiegel, registered psychologist. Hi.
Hi.
All right. Well, thank you all for coming in here today for this conversation. Let's start with what's something, and we can circle back to it later because there's going to be more, right? But what's something you want people to know about mental health care in this province that you think, they might not know? And it's a big, broad question, but you can just, feel free to just cherry pick something you want to talk about there. But I think it's a good jumping off point. Dr. Spiegel, what about yourself?
Hi, thank you so much for the opportunity today. I think one of the things that is really important to me to communicate today is that we work on an interprofessional team in the mental health and addiction system. And so each program typically has multiple professionals, and we all have unique roles.
Yeah, right. And we're going to go through that because it's, I don't know, I find for someone who's not attached to the system as a working professional or anything, I'll think psychologist a lot. And I know there's so much more to it. And we'll get into that part of the conversation of some of what folks understand and also what they perhaps misunderstand. Danielle Hogan, what about yourself?
Again, thanks for having us here.
Thanks for coming in.
I'll build on what Jody said, that we do have teams that are very rich in resources, but as an occupational therapist, I want to promote that there is other disciplines beyond, when we think of psychiatry, GPs, nurses, psychology. I want to talk about the allied health that you don't hear about, that can be really impactful in people's lives and bring value to the mental health addictions programming.
Sean Kennedy, what about yourself?
I think a lot of the discussion today from our perspective is about discovering our ability to be closer to the boots on the ground.
Yeah.
As a community association, how can we work with other community associations and stakeholders to really provide those types of solutions?
Tell folks that as chair of the board for the Canadian Mental Health Association of Newfoundland and Labrador, what does that mean? What do you do?
So for me, of course, our board is a completely volunteer board. And our role as a board with the Canadian Mental Health Association of Newfoundland is to provide structure and governance and provide the ability for the staff, Dr. Chandra Kavna and her team, to drive initiatives, to open it up and provide the autonomy.
What types of things have you been, for folks if they wanted to, I know they can look on the website, but just give folks an idea of some of the stuff that's been going on lately.
Yeah, of course. I mean, within the association, some of the biggest initiatives that we have over the past year are around education, which I know is going to come up in a far more detailed discussion as we move on over the hour. But education is key, and considering various segments and target segments within our population in what education can do. We often talk about needing help or needing resources, where to go and how to get them. And I know our other panel members here are going to talk about the challenges and the unique roles. But what are some of the elements that are driving folks to be on wait lists that we could potentially alleviate? What would it mean if we created a completely innovative educational program in the K-12 in what would allow children to manage negative thoughts and feelings and use tools provided to, maintain what may or may not be called otherwise normal
And this
day-to-day.
is fitting in with the whole social determinants of health side of things, right? You talk about folks need housing, they need the safe housing, appropriate housing, they need proper nutrition, a balanced diet, and also then education plays a factor. Correct me here. I'm looking.
I love what Sean talks about in terms of the education, and we'll talk about it later, I'm sure. But when we spoke yesterday, I love the concept of going into the school system to teach our kids around mental health and addictions. There is also, I think, a need to differentiate between mental health and mental illness.
Yeah.
And I think by going into the school systems and starting with kids, it's going to be phenomenal, because a lot of the folks said, I work with adult populations, so 18 plus, a lot of the folks that come, they don't have those coping strategies, the healthy ones. I'm doing air quotes like everyone can see me, but we're on radio. They don't have those healthy coping skills that they could have learned. The opportunities are available in the school system that they're just not there. I say, there's psychology, OT, therapeutic rec, mental health counseling. We need to be on the ground with the youth, because they will be adults, they will be our colleagues, they will be leaders, they will be our politicians. And wouldn't it be amazing if they had that general knowledge of mental health and addictions?
Yeah, if you front load on better understanding around mental health and mental wellness down the road, that there's a lot of help that can give in any number of ways down the road, right?
Yeah, and it's that prevention and promotion that I can say I don't think we're good at it.
Yeah.
We're really not. I feel reactive in a lot of things that I do because of a system that I work in. I think with Sean's initiative, thinking of the K-12, I mean, the opportunities for promotion and preventative strategies would be amazing.
Daniel, so where do you fit in the system as an occupational therapist?
It's a great question. So occupational therapy, we are licensed and regulated health professionals. We're all university educated. We work in a variety of practice settings across the lifespan. So as an occupational therapist on a community mental health and addictions team, my role is to kind of help people in their everyday living. We are specialized in function. So we believe in a person's desire to thrive in life. So we're really able to get to people's desires, aspirations, their goals, and to really break those bigger aspirations and goals down into more manageable steps. So a lot of the folks that I see come to me, they have challenges with being able to do the things they want to do and need to do and expect to do on a day-to-day basis. So that could be anything from challenges with cooking a meal to getting out in the community, to taking their medications, going to school or volunteering, or even simply just to feel whole again. I hear that a lot. I hear people, they don't feel productive and purposeful. So it's things like that that I can work with folks to kind of believe in themselves.
Yeah. Well, like, so let's just say, I mean, I could be someone in, I don't know, like recovery from substance use disorder, right? And it's just, so you've got that road that you've traveled and you're in recovery, but then it's like, what's my day to day? This is where you come in to be like, hey, I can help you with that and keep things on the rails and help you, survive and then thrive.
For sure. I use recovery language, so I talk about people's journeys.
Yeah.
And I'm so privileged to be kind of I call it a travel meet with people on their journeys. I'm not the expert in their lives. They are the experts. I always say that. I'm simply here to kind of help them navigate the systems, to navigate their lives and their environments, their natural resources, the formal supports that are available. If someone needs to get up to go to an appointment, what do they got to do? Like, we take for granted, we all got up this morning and got here. But those steps it takes to get here, it's, alarm on your clock, getting out of bed, getting dressed, brushing your teeth, having breakfast, because we need food to fuel our body and our mind. So there's so many steps to these things we take for granted that we call occupations. And oftentimes when people hear, about occupational therapy, you think about jobs. We are so much more than jobs. And occupations, when an occupational therapist uses that term, we mean anything in the run of a day that people do, from the moment you get up in the morning till the time you go to bed at night, and when you're sleeping, because we also look at sleep hygiene. So, because we need a restful night, and we need food, we need connectivity. So I could go on forever.
Do you like your job? I feel like you like your job.
I am so passionate about occupational therapy.
Yeah.
I really, truly believe we bring such value to people's lives. But it's not known a lot. So I feel like the more people that we can educate and advocate for occupational therapy, I think it would make a significant impact. And then in conjunction with that is like we can better prepare people to be able to, avail of and participate in psychology, mental health counseling, community agencies. So again, back to that function piece. If we can help people learn how to function within their lives, then they can avail of, other natural resources.
Dr. Spiegel, what about yourself? Where do you fit into things?
Yeah, so we've been in a real transition on the outpatient teams as a group of psychologists. You mentioned earlier some of the struggles have been around recruitment and retention. And so our small crew, we're operating about 40% in the metro outpatient teams. We've been engaged in a lot of different process initiatives to try and really hone in on what our unique role on the team is. And psychologists have a role in assessment and in helping coordinate some treatment plans that make sense for those clients. We also have taken on a lot of work with populations like individuals living with OCD, severe anxiety disorders, ADHD. And in that way, we are doing more of that therapeutic intervention, looking at helping people with their perspectives and trying to look at things from different angles, learning some skills for navigating, as Sean mentioned, their thoughts, their emotions, helping them clarify their values, and really getting to where they can be their most authentic self in their different settings that they operate. Yeah, and what we've noticed through the initiative that we've done, it's called a choice appointment, where we work collaboratively with a client who's been awaiting a psychology service, is that the majority of the people that we're assessing are going to benefit more from other members on our team.
Right.
Or other services, not even our team.
Give me an example.
Yeah, so earlier last week, I assessed somebody who has been waiting a long time for a psychologist, and really, when we got down to it, they're someone who's fairly socially isolated and not connected in the community. And we have a therapeutic recreation specialist, another regulated professional that has specialized training in recreation and leisure as a form of therapy. And that person is so connected. They do programming within the healthcare organization. They also are really connected to leisure opportunities outside of the organization. So I referred that person on to therapeutic recreation. Another person, really their main barriers, they really want a job. And while they do have social anxiety and will need to do some work around that with a mental health counselor or psychologist, they also will need support from an occupational therapist around, some career interest, as well as looking at their specific barriers and how to work within that. Probably some exposure, like getting out and like being in the community in those different job settings. And, these are people who have been waiting a long time for psychology, because that's what either the person that referred them thought they needed or what they thought they needed.
And when we say waiting a long time, what is because now a long time for me can be a bunch of things. What is a long time?
I'm not sure if I'm able to answer that, if I'm being honest, but I can say that it is months to years.
Yeah, that's what I figured, right? I mean,
Yeah.
that's typically what I hear too, months to years. So with that description, right, we're hearing some barriers, perhaps gaps. Might be some systemic things for structure going on. What does that say to you about how the system we have, how it's built, and where should like the changes be brought in there? Because if folks are waiting to see you, and then you get them, it's like, actually, you need to see an OT, or you like a therapeutic recreation specialist would be great for you, right, to learn how to thrive and be well through activity and play and that type of stuff. So what needs to change for that to be more smooth?
I mean, I think we've all spoken about the challenges at the point of intake.
Yeah.
And, there's a lot of confusion that happens at that point. So the adult central intake, which is the intake format I'm most familiar with, they have such limited time. The clinicians have such limited time to connect with the clients, 15, maybe 20 minutes, to get all of the information that they need from the client, very vulnerable information on the phone, that then allows them to determine what the right service is for them. That's an impossible task.
Yeah, because folks could be phoning, whether it's any range of crisis, vulnerability, whatever else, and it's on the phone. There's no trust built up, and then you're trying to get all this personal information out of someone, and then say, okay, now you're in the wait list for this person, as opposed to when it could be B, C, D, E person in the healthcare system. How is that fixable?
I think it is. I think even the process initiative that we've been engaged in demonstrates that it is fixable.
Yeah.
I think part of the challenge is we, as Danielle alluded to, we really don't do a great job of differentiating between mental health and mental illness. And really, everyone's going to have mental health concerns. We have resources for that. Doorways is a fantastic option. I don't know if people are aware of that service, but it's operated 5 days a week, and it's a walk-in service. You can receive counseling immediately. There's LifeWise peer support services. And then because so many people are coming to the doors, the answer then is, okay, well, we need to do shorter sessions to figure out what they all need. It's just not working. So I think if we could figure out a way to streamline the mental health, mental illness, and somehow capture the people who have lived mental illness and do more in-depth assessment, they'll be triaged then to the appropriate resource as a starting point.
Yes, it's just, and part of this as well is like we were at the beginning of the conversation. So it's a education early on to understand mental health, mental wellness, mental illness, to understand what's out there, and then better triage at the point of intake for people to go into a different stream for mental health and mental illness to help ungum the system. Okay.
Yeah,
All
that's one thing.
Okay. All right. Good. I'm just making sure I understand. I was like, I think that that was the flow of for this part of the conversation. So we've got all of this going on. Any other thoughts on gaps or just any other thoughts altogether? Sean?
Yeah, I mean, on a podcast that I was a guest on a couple months ago, and in several other conversations that I've been in, I've used an analogy of twisting our ankle. So I won't fully put you on the spot and reverse our roles here, Adam. But generally speaking, if I said, what do you do if you twist your ankle? There's a societal common knowledge about what's going to happen there. So I go outside, I run off the sidewalk playing basketball with my kids, and I twist my ankle. I know what I'm going to do with that.
Yeah, it depends on the severity, right? Does it blow up? Can I walk at all? Is this an emergency room thing? Is this a me go to the doctor thing? Is it maybe I just need to? But like I've got a very good understanding of the different things I should do, and also around the severity of like the levels of where to go around an ankle sprain. Not a problem.
Exactly. And what to look for.
Yeah.
After 48 hours, if the swelling hasn't gone down, well, that might be a visit to your family doctor to get a requisition for an X-ray. The point of it all is that it is, and perhaps I'm a little bit outside of where I should be, but I use the term a little bit common knowledge.
Yeah.
So what ends up happening is if it's bad enough, you're going to wind up seeing an orthopedic surgeon. But potentially it really only needs ice and rest, and you'll be fine. And honestly, maybe you can walk it off. Yeah. It might not be that big a deal. But in reality here, in a lot of the conversations that we have, what we see are people wind up or think they need to and end up in a lineup to see the orthopedic surgeon. But the opposite is true. Right? We have people who need to see an orthopedic surgeon, but they're like, nah, I can do it. I can walk it off. I can play tomorrow. Yeah. Right? So it's one of the biggest, and for me, in my position, I'm not a professional. I'm not university educated in mental health. So I work to try to simplify the discussions, especially when I get opportunities to speak with folks from groups like the Allied Health Professionals. Yeah. So, I mean, one of the other key points on this subject that I feel is completely relevant is there's no shortage of support. There's not one single person that I've ever spoken to, whether that was a member of government, a leader of a massive organization, community volunteer, a hockey coach, gymnastics parent. There's not one single person out there who doesn't 100% get behind the idea of an improved ecosystem or various initiatives that support mental health. So when it comes to our ability to sort of get in as an organization, the role that we can play in the community, it's about really trying to understand what that pathway within what you just described in the flow from what we just learned is like what can provide the biggest impact. Yeah. What stakeholders or partners need to be involved, and we need to take the initiative to drive that forward. We can't sit back and wait for grants and plans from various governments or all kinds of groups. We have the opportunity here, so we're going to take the leadership opportunity and roll. And if we could talk about ankle sprains or breaks, historically speaking, in a mental health term, as opposed to having the stigma that's been over it for years, we'd probably be in a much better place today. Thoughts?
Yes, I put my hand up. I wanted to add on to both what Jody and Sean was talking about in terms of those barriers and challenges. I always go back to the systematic barriers, and I think that's something you wanted to talk about like a little bit later, but I'm here now. No, now's the time, right now. Talking about like the entry into the system, when we look at healthcare, health isn't just healthcare. So in my role, when someone's coming into my office or I'm meeting them at a coffee shop or in their home and they're having difficulty paying their rent or even coming up with their rent, if they're having difficulty reading a bus schedule because of literacy issues, if they're not able to read a recipe, if they're not able to call the pharmacy because there was a mix-up in their medication, how can I go like, okay, time out, let's talk about your health. Like I need to talk about those social systems, the income, the transportation, employment, education. Like health just doesn't equate to health care. We really need a coordinated pathway, between all systems. The health accord you mentioned is in principle a phenomenal accord. It's got great initiatives, great recommendations and suggestions. It's a 10-year plan. It was signed, I think, in 2022. But what do I do today in August of 2024? What do I do tomorrow? For the folks who are really struggling from those systematic barriers. I've been in the system, myself and Jody talked about this the other day, like I've been around for a while and I have difficulty navigating the system. I get, I get those phone calls where I can't get an answer. So imagine someone who is unable to pick up the phone, and now they're dialing a number and they're pressing, you can't even get a person anymore. You're dialing 1, 2, 3, 4 for different things. And by the time you get to an actual person, someone with anxiety, depression, trauma, they're so flustered and frustrated, they forget what they're trying to ask for. So they can't even articulate what their needs are. So imagine that. So to me, it's like we need more communication, more direct access to one another. So I often use the example from, say, someone mentions they don't have enough money at the end of the month, and a referral will say, help with budgeting. And it comes to me, it goes through ACI, it comes to me through our intake, and I'm going, well, how can I help budget poverty?
Yeah.
Right. I'm good. I can toot my own horn, but I'm not that good. I can't help budget poverty. Like people need a basic livable income. They need their medications. They need transportation. Like we need to do better with connecting with the other services and systems in our world.
Yeah. So like if I'm your client and I live in Gould's, but I've got an appointment just across the road here at Health Sciences, and let's say I've got some my reading challenges, my income, perhaps I'm on social support. Now, to wake up in the morning, like you said, for what was the night's sleep like?
Yep.
What's breakfast going to be like? Is there going to be a breakfast? And then how does this person get out and get to that appointment when they probably don't have a vehicle? And then maybe they're making calls, or they use if they can use the bus. And maybe Gould's may not be the best example, but somewhere where there's bus access.
I cover the Gould's, yeah.
Yeah, right. So then trying to get there, and all the frustrations even if they get to the appointment, even if they are perhaps on time, but all like having that stacked against them just to get there for an appointment, which may or may not be on time, and anything else. I mean, all of that is a lot.
It's overwhelming, and then they have to articulate.
Yeah.
So after all that, and I will tell you, like most people who have an appointment, say tomorrow, Friday, 10 o'clock with me, they're not sleeping tonight. They're not eating breakfast. They're probably calling a cab and using their last dollars to get there because they're afraid that if they don't show up because of policies, I say it's a no-show, and then potentially they're discharged.
Yeah.
So it's just, it's such a domino effect.
Yeah, and to use cab money for what could be your next meal or the meal of the day or whatever to get to the appointment on time, but then we're having this healthcare conversation and health and personal health conversation and the impacts of that.
Right, and it shows the priority that they're willing to spend their last dollar to get to come to a healthcare facility because it means that much to them. So they're prioritizing that over a meal or medication. So that speaks volumes for me that, back in 10, 12 years ago in a position I was in, we had a direct phone number for someone in income support. So I could actually call her up and say, it was a person in an office.
Imagine.
Imagine, 2024.
Yeah.
But she was able to answer our questions like in the moment. So that's the right service, the right time, the right intensity. I mean, these are all key phrases from the health accord. But I can't do that now because we don't have that connection. So how are we to promote wellness from our team's perspective when people's basic needs aren't being met?
So then what are some of because through the health accord also there was conversation around there's been a lot of health spending over the years, not a lot of social spending. And like that mismatch is apparently, according to the folks who know about this and according to you folks as well, this is some of the reason why we are where we are when it comes to health in Newfoundland and Labrador. So there's some big policy discussions there, right? Big things like you mentioned, basic income, other big swings. But for the day-to-day, what are is it that one person who used to be there could be there again? Like, what are some fixes that could make things better right now as the machinery turns to try to reinvent a whole system?
I think one of the things that we keep coming back to is there's no forum for direct communication. And, even on the Metro teams, so we're all theoretically supposed to be doing the same kind of work. I don't know what's happening down the road from me at the Center City team, because there's no forum even for those 4 geographic teams within Metro to come together. Now you add on to that other systems, other services, even within the healthcare system, community agencies. People are constantly changing their names.
Oh, hey, believe me, I understand. People email me. I'm like, who's this? Oh, it's you. I didn't know that this happened.
Right.
Yeah.
And so for me, I've been working at NLHS since 2001. I mean, we've changed our name 3 times. And, just that awareness of how much things are continually changing, and there's no touch point for the communication. And so I just imagine somebody who has, really limited resources is very vulnerable because of the illness for which they're coming to see us. And I don't know how they're getting through. Yeah. So I feel like adding some more of those forums for communication and not just like a once a year kind of thing would be really helpful. And also not relying on going to websites to check it or putting the onus back on the provider, because our work has shifted so much. We're doing a lot of tasks that historically were administrative duties, historically were managerial duties. And so in taking on all of that extra, we really don't have the capacity to be reaching out constantly. Hey, what are you doing now? What are you doing now?
No, that kind of thing would have to be baked into the system, right? So feedback that's baked in so people can know, I know what the other teams are doing. We have a good idea. But even with that, something that doesn't just bog you down in detail. And for some just to say, in anything, I know we're talking about healthcare today, but if it's complicated stuff, check the website. It's like, that's not, I'm a busy person. To spend a couple hours mucking through a website that I may or may not be able to navigate is not exactly an answer. I'm just thinking of stuff in my own life. But anyways.
And not everyone has internet. Not everyone has a smartphone.
No.
Right? So.
Or you go to some of the fast food restaurants and you see folks who are accessing internet just there for the time to try to get to their appointments.
Exactly.
With a little cup of coffee next to them.
Yeah. To answer your question, I do see a role, and I don't think it would be. I mean, I guess I can't say that, but I'll go back to I see a role for direct lines to housing, to income support, to the transportation folks. There's great policies out there. I don't write policies. I've never been involved in policy writing, but I can read them, and they don't make sense of reality.
Yeah.
When someone's sitting in front of you, a policy does not fit. So if we had someone to connect with to say, hey, how about this instance? Because everyone is different. It's not a cookie cutter approach.
It's feedback and communication. Right?
Yeah.
Feedback and communication. And so then if something comes in, it's like with the best of intentions, right? With a policy that comes down, and there could be some great stuff in there, but at the same time, but I don't understand this, and this.
Yeah.
And along those lines, Adam, to build on what Danielle is saying, we're not at the table at the beginning of these discussions when policies or programs or services or new models are being created. So it has felt historically that when we're invited, things are already decided, and it's almost a box that needs to be ticked to say, well, we did have the frontline workers' input. And a lot of times, when things roll out, as Danielle said, it does not make sense for our population. It may work fantastically in Metro Toronto. it's not going to work the same here. And then when you bring it into rural Newfoundland, to assume that what we're going to do in the east end of St. John's is the same as what we're going to do in CBS, is the same as what we're going to do in Marystown, it just doesn't make sense.
Oh, we just did our whole show yesterday on healthcare and transportation, right? So I know I mentioned Gould's, but Happy coming down from like Makovic or Nain or Happy Valley Goose Bay or any rural parts of the island, trying to find your appointment with your healthcare provider. Is it going to be at the local hospital? Is there a local hospital, or are you coming into St. John's? Like, all of that is just stacking extra cost and stress on people. It's all there. You're listening to The Signal. I'm Adam Walsh. If you're just tuning in and wondering, I think you'll know what we're talking about if you've been listening a little bit. But for today, we are talking about mental health care and mental health professionals working in the system. We are, talking to them about what some of the challenges are, what some of the barriers are, what some of the fixes could be, and what that could mean, right? In this case, we've been talking about what increased communication and feedback could mean for the system of tomorrow in a world where we have a health accord that is reinventing our healthcare system and trying to make things better for Newfoundlanders and Labradorians. My guests in the studio: Sean Kennedy, Chair of the Board for the Canadian Mental Health Association, Newfoundland and Labrador; Danielle Hogan, a licensed registered occupational therapist; and Dr. Jody Spiegel, a registered psychologist. With the rural-urban divide in your jobs, what do you notice about that? Just as for what you do on your day-to-day, like how much does that come into your thinking when it comes to your practices?
Well, I can certainly start. So as mentioned, we have done a lot of different initiatives with our small psychology group. And there are one psychologist and soon to be a second psychologist working in Clarenville and Burin. And what we hear really from the more rural psychologists is that there is a lot of overwhelm, because as much as we're trying to do a lot and our roles have expanded significantly, theirs have become just untenable. They're across the entire lifespan. They're across very large geographic regions, and they're, really trying to meet everybody's needs.
Mm.
I've never worked rural. I've always been in the urban regions. I did speak to a couple of my friends, colleagues who work in rural, just to kind of get my head wrapped around it. Their challenges are similar to ours, so they mirror ours in terms of those systematic barriers. But what they highlighted was more around, again, transportation, because if I think we don't have transportation, adequate transportation here, I can't imagine in rural.
Yeah.
They have challenges, again, around income. They have challenges around resources. So they talked a lot about the availability of specialized programs that we have access to here in urban. Again, in urban, we have so many community agencies that Sean talked about. We have availability to, I can go out and pick a client up and bring them somewhere within the community, because that's part of my role. But like Jody said, the vastness of the geography of our province, that's not doable for a lot of our OTs that are working in rural areas. So yeah, I can't imagine doing my job in rural, because I know what I struggle with day to day. So.
Yeah, from our perspective, especially at a high level, once we start talking rural, it's exponentially worse.
Yeah.
It's part of the Canadian Mental Health Association National's mandate to continue to expand into rural communities in some way. And actually, right now, I'm not 100% certain on timeline, but we're opening CMHA-NL office in Labrador.
Okay.
Speaking internally, when it comes to strategic discussions in the role that we want to play, that is always at the forefront in how we're going to work to find solutions. I know there are a number of groups in the province who are actively working together from a capital perspective to create very strategic and specialized initiatives to help develop the rural regions in this specific conversation. And we're trying to get behind it and work in that space as much as possible.
Mental wellness for mental health professionals, for your colleagues, for yourselves. Whenever we'll do shows or in the news from folks who I know in the community, I hear about burnout. I hear about the stress. So, when you hear of, my team's at 40% when it should be, a lot, preferably 100%, but, like more than 40 anyways. Or we talk about some of the struggles in rural Newfoundland and Labrador. What's it like right now for wellness for the working mental health and healthcare professionals that you're around?
We're all making eye contact with each other.
Yeah, exactly. There's a lot of side-eyed eye contact going on right now in the studio.
There's a lot I could share, but I think to keep it simple, I think I can say we as a collective, because I have close relationships with my colleagues who are friends. We're tired. Yeah. We're really tired. I want to qualify, though, we're not tired of our positions. We love our work. We love our professions. We're tired of the injustices that occur day to day. We're tired of, the administrative political issues that keep coming up. We're tired of the miscommunication or lack of communication with us. We're the ones who know our positions. We're the ones who speak directly to clients day in, day out. So we could be part of the solution. So I guess I know I'm tired of not being able to provide my input for solution-focused care. So yeah.
And I think that must make it, because earlier in the conversation, when we were talking about input, right? And then if someone's waiting to see, for example, a psychologist for 6 months or a year or 2 years or something, and then they get in and it's kind of like, actually, you should have gone there. I can imagine that being a very frustrating experience once it happens over and over again. And that also can lead to being tired too, right?
Yeah.
Like seeing things where you're like, this is fixable.
And you're sometimes the first person that somebody sees, right, when they're waiting on those wait lists, or they've gone through the entry to services. So when someone's sitting in front of you and you're like, oh, I don't know if I am the right fit for you right now, I'll always say to folks, I will go through the referral with them. This is what you were looking for back so many months ago. Let's figure out if you're still there, because life happens, obviously. And I'll always say, if I'm not the correct, most appropriate connection for you right now, I'll help you navigate. I'll help you get to who you need to get to. So I do try to help, with their frustrations. And they're often very defensive, irritable, angry, aggressive. But I understand it, and I validate that, because I also am a consumer. I go to GPs and I go to physio and massage and chiropractor. So I can understand trying to enter into the system. But we also have mental health. So I think sometimes I like to stress that we also have to take care of ourselves. We need to be the healthiest we can be to be able to provide support to our clients and communities. And sometimes there's a misconception of we're human. We listen to stories every single day.
That's a lot.
It's a lot. But I'm very appreciative of my team. We have great connections. We have great debriefing sessions. We're trained to take care of ourselves. I can fill my tank up. I can fill it up from a personal perspective. My passion is to help other people fill their tanks.
Yeah.
And sometimes that's difficult.
Dr. Spiegel, what about yourself?
Yeah, I think we walk around sort of shaking our heads, looking at the injustice and these vulnerable individuals that we went into this profession to help, and feeling helpless ourselves a lot of the times, which is a really hard experience. As Danielle said, we validate for the people we're working with. This is not fair. Yeah. It's not fair when you're experiencing an illness to advocate so much for yourself, especially if that's something that is a part of why they're coming to see us, if they struggle with that. Many people, as an example, with depression feel like they're a burden and taking up space. To ask them then to say, I need this, it's just really unfair. It's demoralizing. It's also very defeating, watching the level of attrition over, like, the amount of people that leave our organization it's heartbreaking. It's a lot of loss.
How does that get reversed? Because that was leading as a great segue into my next question, actually, because I was going to talk about recruitment and retention, right? And if you're losing folks and then you want to operate with like a full cup, right? But then if your team's not at 100% and then you've got everything else that's being described, how is it for the young folks who are coming up through and getting their educations now and being like, you know what? I want to be a psychologist working in the system. I want to be an OT in the system, when there's a reality of this system, and we're planning to be 8 or whatever years from now with trying to fix as much stuff. There's still lots of issues that are going on. How do you bring people in? How do you reverse this?
So I think, one of the things that's been interesting to me, so we have a psychology predoctoral residency program, and in the past several years, there was a trend toward people really choosing the private sector. Yeah. I feel like we are starting to demonstrate, like, this is still a really good place to work. As Danielle said, as colleagues, we support each other. We're engaging in a lot of innovation and really, like, collaborating. That's a very huge strength of working in the public sector, is being able to have that collaborative interprofessional approach. I think part of it is that our system has such a bad reputation now. Yeah. And I think it's important that people not conflate that we have such challenges with that it's a bad place to work. It's not. It's a fantastic, I love my job and I love working where I work.
It's a bit hard to hear. It's a bit hard to listen to. It's, it really is one of the key benefits of having the privilege of sitting around this particular table. Yeah. When we think about some of the ways that we can learn from each other and find ways to work together. I do like that Jody brought it around to a positive trend. And in other aspects of my professional life, as well as within the Canadian Mental Health Association, it's a hot topic, and it extends all the way into the employee benefits discussion and involves the insurance ecosystem. And I know there are innovative programs, new products, and increased investment from corporations across Canada, at least, that seem to be making a difference. I have to believe, and understanding and hearing more about some of the innovative programs that you folks are putting together, that it will trickle in, because you're right, the discussion is not new, and that trend is fairly consistent. And you had mentioned earlier that we were operating at around 40% of the professionals that we need within our system.
I want to clarify, I'm speaking specifically about psychologists on
Noted.
Noted. The teams.
Noted. And I'll for the record, I'll say I read that. And again, one of the points that I made a tiny bit earlier was there are no folks involved in the system who I've connected with who haven't fully put their hand up to suggest that we will get behind an initiative that makes sense, that can make a positive impact. So sort of seeing some of those trends, hearing some of the positivity, and some of the outside conversations, there's a little bit of optimism to take away from this discussion, in my opinion.
Yeah, well, that's why I like doing these types of shows. It's hearing from folks like, what's your reality? What are you hearing? What's working? What's not working? How do we make it better as time ticks on and as changes are made? Right? There's a feedback loop. There's a whole ecosystem to the society which we live in, and us having this conversation today is part of it. Danielle, what's a pitch for folks who are, or what would you say if someone's thinking, you know what, I like working with people. I like making an impact on people's lives. Maybe I want to be an occupational therapist. If we're talking recruitment and retention, what would you say to them?
How much time do I have?
You got 3 minutes.
I think occupational therapy is really a grassroots profession. We have a lot of students coming through. We are a small but strong membership. We have a phenomenal provincial association. We have a phenomenal national association. We really aim to kind of build each other up to be able to build our clients up across the lifespan. Like if you like relationship building, if you like, watching someone's journey and being involved in something so vital to a person's life, like come on over to the occupational therapy side.
So then for you, and there's success for the client, for the individual. Like those successes could be any number of things, right? I mean, that success could be timing for breakfast, getting that bus. But for you, what's the success? What's a success story or something that kind of sticks with you? You're like, oh, this is the OT gig. This is why.
When a client can say to me that they feel proud of what they've done, when I see a smile on their face, like a genuine smile, because a lot of our clients mask a lot, and that's just a coping strategy.
Totally.
But when I can watch someone along their journey and travel with them along their journey and then see them accomplish, I've seen people walk across the stage and get a high school diploma. I've been invited to high school graduations, ABE graduations, post-secondary. I've gone to people's work and I've hidden in parking lots because I just want to, they want me to see them go in, but I don't want to be seen watching them go in. So when I can go to a coffee shop and when someone can have a conversation with me and it's a natural, organic, fluid conversation when nobody around us knows that I'm an occupational therapist and the person in front of me is a client, that's success to me. Like when people can feel that they belong, that's something like that sense of belonging in a community and a belonging in their own bodies, their own minds and their own souls. To me, that's occupational therapy.
We've got about a minute and a half left. Dr. Spiegel, what about yourself for the success side of things?
Yeah, I think, really similar to Danielle, when people can really be their authentic selves, really live a life aligned with their values, and be able to live with sometimes very serious and difficult symptoms and still live their most authentic life worth living. That's a huge success. I always say the best case is when I work myself out of a job.
Yeah. There you go. And this is why you're doing your jobs for both of you, right? And you can hear it and passion behind it. Sean, I'll give the last word to you because we're almost out of time. So any final thoughts as we leave?
Just to thank you, I think. This is very mind-opening for me to sit and talk with you folks and what it means for what we can do as a whole together. So I appreciate it a lot.
All right, so that's Sean Kennedy, Chair of the Canadian Mental Health Association, Newfoundland and Labrador. Also here with me in studio, Dr. Jody Spiegel, registered psychologist, Danielle Hogan, licensed registered occupational therapist. Thank you, folks, for this.
Thank you so much.
Thank you.
All right, everyone. If you have thoughts on today's show or any show, The Signal at cbc.ca. Call the Signal line and leave us a message, 709-576-5260. So we did 2 back-to-back healthcare shows. Tomorrow's it will touch on health in a way. For tomorrow's show, actor, writer, and producer Renee Hackett is going to be my guest. And we're going to talk about a new podcast that she's launching called Can You Hack It? Get it? A show that dives deep into the curveballs that are thrown at women and Renee's belief that when faced with the hard stuff, they can hack it. Tomorrow's conversation, women-focused, and we're talking menopause. That's tomorrow's show. Until tomorrow, thank you so much for listening. As always, we'll be back in a day.